put our implants. This is very important. Next step, it is reduction. So this is 4 steps. Reduction should be realized never on one implant because it may lead to implant failure or bone failure, screw pull out, etc. So we should do the reduction on multiple implants at the same time. Like you can see here, I used the translation technique on 1, 2, 3, 4, 5, 6, 7 levels at the same time. So this is very important to distribute the forces on all the implants. The 5th steps, before the end, we have to prepare the bed for the graft. So I use the old technique of decortication, as you can see here, and the bed of the fusion is very important. So I prepare that thoroughly and meticulously, and then I will put the bone graft as you see here. This is only autologous bone graft coming from facet and decortication. And you can see the amount of bone that we can have. So it is not necessary to use any kind of bone substitute in AIS. And even an adult, I don't use very exceptionally bone substitute. If you don't have enough bone, it means that you did not do enough release, enough facetectomy, and enough decortication. Usually you have enough bone, and you can see here the amount of bone that we can get. And as an example, my incidence of pseudarthrosis in young adult below 30 or in adolescent is 0. All the pseudarthrosis I have more than 30 or 35 years old. So it's very important, no place for pseudarthrosis in children and adolescents. The last step is closure. I use vancomycin before closure. I don't use drain. This is personal, so I don't use drain, neither in adult or in children. About the approach, this is what we used to use for thoracolumbar curve years ago, and the advantage of that at that time, you can see here a case in 2005 I operate with complete correction by anterior approach. At that time the advantage was to decrease the number of vertebrae fused on the lumbar spine. But now with the technique of multi-level pedicle screw and wide release, we can have the same number of vertebrae fused by anterior or by posterior approach. So the advantage of the anterior approach decrease with time. Some error to avoid. So this is a case of AIS. You can see that the L1, L2 disc is kyphotic. So in these cases, we have to avoid stopping an kyphotic disc. So this is one of the errors to avoid. You can see here that we include this disc in the fusion. Another error to avoid, look here, the end vertebra is L1, but it is not touched by the medial sacral line. And you can see here after surgery the bad result, and I had to do revision for this patient because of adding on phenomenon, and I had to include 2 more vertebrae. So in this case, the level choose was L1, and the L1 was not touched by the CSVL, and also it is a King 4, so it's a specific type of curve, which usually fusion should be longer. This is another case. This is more interesting one. In this patient, usually if I have to operate this patient, I would take only the thoracic curve. But if I have to take only the thoracic curve, I have to stop on T11. And this is what I said. If you decide to take the thoracic curve, you should not include lumbar curve inside the fusion. Or you decide 1 curve, or you decide 2 curves, but not 1.5. And look what happened. The surgeon did 1.5 curve fusion. So he did not decide to do selective, and he did not decide to do treatment of the 2 curves. And you can see the progression, and I had to do revision surgery for this patient, taking 2 more levels. So this is very important. First we decide the curve to fuse, and then we decide the level. So in this case, if I have to operate, I say it again, this patient from the beginning, I would do only selective thoracic fusion stopping on T11 or T12, but not on L1. But probably I would stop on T11. So the take-home messages from this presentation, I would say that surgery is indicated for curve more than 35 to 45 degrees. It depends on the location mainly. Linke classification is the most used, and it is correlated to the surgical indication. When a curve should be fused, the fusion should cover all the curve. When posterior pedicle screw instrumentation is used, it's now the gold standard, and it allows the correction of the thoracic kyphosis. We did not talk about that, but the cases I showed, we can see the correction of the thoracic kyphosis with pedicle screws. It is not really true that it flattened the curves. It depends on the technique we used and not necessarily on the implant. I think meticulous planning and respecting some easy principle permit to avoid many complications. Thank you for your attention.
Thank you very much, Ibrahim. We have time for several questions in the assistants. Is there any question about this lecture before to go forward for the next lecture? Yes, Dr. Bouchoucha.
Thank you. What do you think about gibectomy in very important deformities to increase the amount of correction and to improve the physical aspect of the patient? Do you perform gibectomy?
Yeah, thank you for this question. I think at our time now, it's extremely rare to do gibectomy for many reasons. First, we are treating scoliosis at lower angle and at lower age. So I think it's only for neglected cases that gibectomy may be useful. The last one I did, I think it's more than 10 years ago, and it was a patient already operated for his scoliosis at 20-something of age. So it's very rare that I use gibectomy to improve physical aspect of the patient. The second reason, so first we are operating them younger with less angulation. Second is that the correction allowed by the new technique of correction is much more important and improve better the physical aspect than the older technique when we used to use hooks or when we used to do anterior and posterior approach to release, etc. I think by posterior release now we are able to improve the curve from more than 100 to almost 30 degrees, and the correction of the hump is really very important. So now I'm using much less. And the other side, what I can do is concave side rib resection to improve the flexibility of the curve. This is something completely different. It's in the very severe cases, we can remove the rib head from the concave side associated to the facetectomy and sometimes to the facetectomy of the upper facet. But this is really severe case, more than 100 degrees and more than 18 years old. So in these cases, I can do some rib resection from the concave side, and very often we don't need to do gibectomy in these cases. So costoplasty from the convex side.
Thank you.
Thank you. Is there any question?
Okay.
I have one single question for you, Ibrahim, about I know that you are fond of freehand technique in this kind of surgery, and with the navigation supports now, and you know that in Tunisia we don't have any kind of this support. So do you always deal with this technique even in very severe deformity cases, or you count on other devices? And the other the other question is, you have talked about the place of the anterior approaches. Is there any indication in your mind about